Good afternoon to all of you. Welcome to Capdular webinar. This is an important webinar to us, and it is our second webinar in English and our third on the topic related to pain and surgery. And we are very pleased to see such a large audience. So within Capdular, we're very proud to have the opportunity to share with you all this exciting project that is IGOS, and welcome our three lecturers for today, Professor Viguier, Dr. Buttin, and Dr. Fauqueux, who are going to tell us more about this group and share some clinical cases. So just a few logistic points before we start. The lecture will last approximately 40-45 minutes to save time for questions. So between the different sessions. So if you have questions during the lecture, please use the chat and we will answer as many as we can at the end of each part. So I'm now handing over to Victor Robalo for the presentation. Enjoy your lecture.
Hello everyone, so my name is Victor Robalo and I am representing Novetech Surgery, who supports the IGOS veterinary group. So I will let Eric Viguier, professor from Vetagro based in Lyon, France, for starting this conference. Thank you.
Hi everybody, I'm very happy to be with you today. I am Eric Viguier, professor of small animal surgery, diplomate of ECVS, and I worked with the Novetech surgery since now more than 3 years. And before, I have the opportunity to work with intra-articular ligament in dogs with this new technology, new way of surgery. So today, I will try to present you all the new thing that the Novetech and IGOS group has developed, and particularly the platform to present how the IGOS can now promote the surgery and give to vet the best way to improve the surgery. The goal of the IGOS innovation group for orthopedic surgery is to develop and study the minimal invasive surgery. It's very important because the people, the clients now, our clients really want to have more and more minimal invasive surgery. And also we need to have also more physiological techniques and to have best results. The second way is to, when we develop new technologies, we must have a good ethic and be sure that we do is a real improvement of the treatment. And really, by this new platform, we will be able to share our cases and to be able to analyze the results and to be to have more information concerning the improvement of the technique, or in some case, if we have trouble, you have some accident, we can we will be able to find why we have this kind of accident or this kind of bad results, and we can modify, because we have the different way to improve. We have the biological way, we have some biomechanical way, and you have people who have very, very good experience and surgery. And among all the vets who are with us, all the guys, the surgeons who are in the IGOS group are able to bring more information and to share their experience. So now we will present the platform IGOS to us, and Victor, you can present the IGOS software. Victor, first slide, please. Thank you very much. So this is the first page of the IGOS, and you can choose different questions. So it's easy to read, so you can read the text, and it will be I think better for you. We have developed many studies on the repair of the Achilles tendon, and also, techniques to repair the cruciate or reinsertion of some ligament who has been ruptured.
Okay, so I think it's quick time for questions if you have some for Eric Viguier.
So I think now we can present some cases, clinical cases, because François, are you ready to present?
Hello, everybody. Thank you for coming for the first IGOS webinar. Whoa, not so fast, please. So I'm François Fauqueux. I'm an orthopaedic and soft tissue surgeon in Gap in the south of France. Thank you for being there. And I will present two cases, in fact, of tricipital avulsion treated by Novaten 4000 tendon. Tendon basis with an early follow-up, 45 days follow-up on 2 cats. Okay, next slide, please. Tricipital avulsion in cats are
So it seems that François has some difficulties with internet.
I'm back. Sorry for that. We have some internet problem over there. So I said we don't have a lot of tricipital avulsion in case. Only 6 cases are described in literature. All of them had a traumatic issues, and they were treated by suture, tendon suture, reinforced by bone tunnel and protected by a cast. So next slide, please. The diagnosis, all the cats were lame, they couldn't walk on their leg. We had a belly triceps, and, which was worse than usual. We did not have any improvement with NSAID. And what we can say is we had a classical radiographic and echographic imaging. Can you pass the next slide, please? So we have those 2 cats. These are 2 females, 13 months old. We have Pussycat, which is 4.5 kilograms, and Pirouette, which is 3.9 kilograms. Sorry, I'm just... Okay, so we, on the radiographic and echographic imaging, we have the same lesion. And on this lesion, we have a little pieces of bone which are part of the tricipital ligaments that are tied off some olecranon attachments. On the left and on the right, you can see the echographic imaging and with the rupture of the fibers. So next slide, please. I choose Buttin's technique. Well, it's a modified Buttin's technique. In 2018 at the ECVS, Philippe Buttin has presented the case of Chaussette. It was a salvage on a tricipital rupture on 7-year-old spaniel. And this dog has many surgery after mundane accidents. And there was a real failure on the tricipital attachment. So Philippe used a Novaten and a bone tunnel interference screw. And after putting the dog in recurrency with Robert Jones, the dog had a complete recovery. Next slide, please. Why did I have to modify the Philippe Buttin's technique? It is because the interference screw is initially in the olecranon. But if I had a break of the olecranon, if I had a fracture of the olecranon because the screw is really huge, it will be a major complication because those teeny bones won't be easy to fix in case of rupture. So I choose to be lower than the hand-bone ligament. And I choose also the largest part of the ulna. But in those cases, with this so big interference screw, we need a plan B and a plan C in case of complication. And you will see this complication occurs. Next slide, please. So here we are. We have this the body of the muscle and the tendon, which is retract. We have a buried muscle, and you can see the rupture at the side, next to the olecranon. Next slide, please. First of all, we make the first tunnel with a 2.7 drill protected by a sheet from the top of the olecranon to the lateral side of the ulna. So we just drill across the olecranon. Next slide, please. And this is a clever part, I think, that Philippe found. We will stitch the prosthesis in the groove that we made by opening the muscle and the tendon. We put the tendon in the groove, and then we stitches with with classical PTS 2.0 with X style stitches on each side of the muscle. Then I close the muscle and the ligament over. Next slide, please. Once done, we use a guy wire to put the prosthesis through the canal. It works quite well, even with a 2.7 millimeters tunnel. Next slide, please. At this time, we choose the tunnel for the interference screw. We put a 1.1 K wire in the good direction, which is lateral, medial, caudal-cranial, distal, proximal way. And once this pin is fixed, we use a cannulated drill 3.2 millimeters to drill the tunnel for the interference screw. Next slide, please. Once done, we have to thread the ulna. So we put on the interference screw, we screw it on, then we screw it off. After that, as the same way we passed the prosthesis in the early cranium, we pass it through the tunnel of the ulna. Then we keep a good tension with a clamp. We tear the prosthesis till we have no movement of the tendon next to the cranium. When you move it, extension and flexion. Next slide, please. When you have the good flexion, you apply back the interference screw in the tunnel, in the interference tunnel. You screw it on, and then you can cut the prosthesis you have over. Next slide, please. And it's at this moment then we can have major complication. On the left side, we have pussycat. There were no problem with pussycat because it's a 4.5 kilograms cat, quite big. So we have some material to put the screw in. For pirouette, it was more complicated, and when we put on the screw, when we screw it on the interference screw, we hear a bad crack. It was the ulna that was cracking, so we fractured the ulna. Immediately we stop and we put a lower tunnel, a lower screw, and we use a guide wire to ensure that the forces will be good, and we won't have another crack. So we put it either, and we cut the extra ligament. Next slide, please. After that, we have to repair the tendon. I usually use Kessler suture. I like them, I use them, but it's not the best suture for ligaments, for tendon or ligament reparation. If you do that, you should prefer the 3-loop suture, which is a really good biomechanic suture, and don't let gap when put in tension. So prefer the 3-loop play if you do the same kind of surgery. Next slide, please. So this is post-op, immediate post-op. As you see on the right slide, you have the interference screw, which is below the screw on the left side, and it's on the opposite way. Even if on this radiograph, the right photograph is inversed, so you can see the screw is in the other side. That's why I made that because at the first screw it on, it cracked. So I choose this way. Next slide, please. On the lateral view, you can see where the interference screws are placed. In post-op, we don't have any trouble in pronation, supination, extreme flexion, and extreme extension. And it worked well, no interference at all. Next slide, please. In immediate post-op, we use NSAID, meloxicam, for 6 days, morphine drugs, fentanyl, no antibiotics, and mainly no external contention, and that's the point. Next slide, please. We have only a small bandage on the elbow, and the cut goes on, like that. Next slide, please. So we are 15 days post-op, everything okay, no bone crack, no bone fracture. Yes, we got it. And you can see it's pretty good. Next slide, please. So you can see, next slide, it's okay. Victor, next slide. Oh, it's a video. Okay, we have this 15 days follow-up. As you can see, the cat are walking. This is Pussycat. We are 15 days after surgery. No bandage, and the cat has a good walking. Pirouette is more comfortable. She's a little painful when you have your forearm manipulation. It's pronation and supination, which is quite difficult. Next slide, please. Hello, I've lost on you. Okay, so as you can see, Pussycat even jumped in the room, so she was really comfortable with that surgery. Otherwise, Pirouette was more shy, and it was quite difficult to let her walk, so she just sits and don't move. We just have some pain manipulating pronation, supination. Extension and flexion were okay, so that was good. Next slide, please. So this is 45 days follow-up. Okay, we have a good improvement at 45 days follow-up, and you can see a good healing of the bone. So that was okay. We don't have any catastrophic issues. And that was great for me for those two cases. Next slide, please. As you can see on the right dia, we have a little swallow of soft tissues. And we still have a little trouble when we touch it at 45 days, but it seems to be okay. So can you send the movie, please, Victor? So this is 45 days follow-up. Well, Pussycat is quite okay. She's just leaping for the first step, then she walks and jumps. When you manipulate the arm, you don't have any trouble. No pain, flexion, extension, pronation, supination. Well, she's too shy, cold walking, cold lameness, but her owner, she played well, she can jump, and she had good follow-up. The owner is really happy with that. So what about the echographic imaging? Next slide. 45 days, we have a longitudinal cut and an echographic. I don't know if you, yes, that's better like that. We don't have any reaction around the ligaments, and we have a good integration of the prosthesis to the muscle. We don't have any trouble over there. And next slide, if we do a cut, transverse cut, you can see the U shape of the tendon because, as I said, you open the belly of the muscle and you apply your prosthesis at the groove of this opening, and you stitches all at each side the tendon to the muscle. Then you close the muscle. That's what you have in the transverse cut. It's a U shape of the prosthesis over there. Next slide, please. So, as we said, we don't have any trouble and have a good improvement on the two cats. Next slide, please. Okay. Can you skip the video? Yes. On conclusion, we did have a good improvement without external contention, and that was great because I don't like fibrosis on articulation. We had a fast recovery, that was good also. What was bad is we did have really big interference screw. It's really huge compared to the size to the ulna. So we need to add the next generation. Please, Victor, give us the 2.53 and 3.5 interference screw, and that will be great. Thank you for your attention. Do you have some question?
Okay, it's a very nice case, François. I think, yeah, a lot of people are congratulating you. You can see in the chat some of them. Any question about the case? So very, very nice. Thanks a lot, François. I really appreciate the case. Really, Philippe Rochaud also, like Hélène Pommelet and a lot of people. Okay, so yes, I think that Novetech is coming with these interference screws that you are waiting for, and they are, I think, are going to be the construct will be a PEEK, so PEEK. So it will be very, very nice, and you will appreciate that for your case. So now we are going to talk about another case that I had to deal with. It was a real crazy case because of the severe injuries that this dog had. So next slide, please. Yeah, I forgot to tell you that it's so it's a severe sprain of the stifle. It's quite uncommon orthopedic pathology. We can see some, of course. They are mainly traumatic, and it's a combination of ligament and tendon rupture. It is very complex sometimes to have good results, and it's surgically challenging. We have a lot of different techniques because, of course, there is a lot of different cases. A severe sprain depends on what is the ligament injured and how many and how strong is the instability. So next slide, please. This report is about Kinai, this dog. He is a Bosseron of 2.5 years old, weighing 28 kilograms. I did the orthopedic exam and had a positive drawer sign and tibial compression test, but in fact I could even luxate the knee, so it's a real major instability and also a major instability in varus. So of course you will understand that the collateral lateral was sore. We had no skin infection, which is very nice because it was a traumatic case, probably an HBC. For those who doesn't know it, it's hit by car. So this dog had a big injury, and so we performed X-rays, and we knew that there was a 28 degrees tibial slope and a varus instability major with, of course, synovial effusion. Next slide. So the diagnostic, at least, was a cranial cruciate rupture, a caudal cruciate rupture, a complete rupture of the lateral collateral ligament, but also, and I didn't know that before doing the surgery, I discovered it during the arthrotomy, but we discovered that there was also a rupture of the common extensor of the fingers, which is really not common. Next slide. So we use 2 implants of Novetech surgery. It's a Novalig 4000, which I used to repair 3 ligaments and 1 tendon. We used, for the cranial cruciate rupture, a Novalig 4000, but also a TPLO plate from Dupuis-Santes. I did also the lateral collateral ligament with a return of this Novalig. We performed also a repair of the ruptured common extensor of the fingers, the 4000 or so, and the cranial cruciate rupture was repaired with the return of this ligament. All implants were secured with interference screws, and especially in common holes which are perpendicular to the tibia and the femur. You will discover that later. Next slide, please. Yeah. Okay, so there is a mistake in this diagram. I'm very sorry. We will correct it for the next time. but you will get the idea, and it's good. You will see all the femoral tunnels that has been done. So one is done here for the cranial cruciate ligament on the lateral side, and for the caudal cruciate on the other side. Next, we'll show you the drilling field with an interference screw for the cranial cruciate ligament. The other tunnel was for the caudal cruciate ligament. Next, we'll show you the transverse femoral ones that will be needed to secure with the interference screws the implants. And next, we'll show you the common drill on the tibia. So next, we'll show you the pathway for the ligament, for the cranial cruciate ligament and common flexor extensor. And with the common extensor has been stitched. So there is a drill inside the condyle, in the femoral condyle, to go through with the implant, and at the top, at the very proximal end of the implant, it is sutured to the common finger extensor. Next, we'll show you the other implant, which is resolving the caudal cruciate ligament and the lateral collateral ligaments. Next slide, please. So you will see the interference screws that has been put, and then again, yes, and then you can have an idea at the end of the surgical technique. You will see that we put a TPLO plate, which is also securing the implants, because the TPLO plate has been also used for compression on the bone of the ligaments. So it is also another security. Next slide, please. So you need a very, very good pre-operative preparation. Of course, you have to do it like if you are going to do a total hip replacement. So you need the higher level of asepsy. You are going also to suture the skin to the drape. Next slide will show you the beginning of the surgical technique. I had, for this technique, because it was a real disaster, I had to do I had to do a medial and lateral parapatellar approach. And this is when we visualized that the common extensor digital was thrown out. On the next slide, you will see that we are drilling here the caudal cruciate ligament. Next slide will show you how we drill with the guide that Novetech has developed. We are doing the other side with the cranial cruciate ligament. Next slide. I'm not detailing all the technique, because it's very technique, of course, and it's very, very long. So I'm not able to explain everything, but it's all the big steps. This is a perpendicular drilling of the femur, one of the two we had decided to do. On the next slide, you can see that we have performed the tibial plateau leveling osteotomy, and have done the drilling of the tibial caudal and tibial cranial ligament cruciate ligament tunnel. Next slide. Oh yes, so it's the same. We had the drilling of the tibial caudal tunnel ligament. So next slide. So this is a perpendicular tibial ligament tunnel that is a return. So it's just underneath the osteotomy. Why? For two reasons. I wanted to have a compression of the ligament by the T-pillow plate. So that's one of the explanation. I put it not far behind, in front of, or on the side. I wanted an interference between them. Then we have on the right picture, we can see the placement of the Novalig. So you can see it coming. On the next slide, you will see also the caudal cruciate ligament. Oh no, so on this slide, yes, you can see how I did the tunnel inside the fovea, which is the antithesis of the common extensor. And you can see also how the implant is going through, and it's sutured on the right picture. Next slide. This one is showing that the two implants, both the cranial and the caudal cruciate ligament implants, are going in the same hole on the return in the tibia. Next slide. So this is the next step. I couldn't detail everything. It's a real long surgery. By the way, I think I had 2 hours surgery on this one, which is quite long. So I don't explain it, but of course, after I had to place the return of the lateral collateral ligament to reinforce this collateral ligament, I had to put all the screws, as you have seen it on the diagram, and to put the T-pillow plate. So that must be for you a very big question. Probably I will have some question about this. Of course, you should say, but how you do it not to go inside the implants that you have already done. In fact, maybe I was lucky. In fact, I really eyeballed it. With TPLO, you have a guide that is secured and screwed inside the plate, and when you put your drill bit inside it, you can really eyeball and see where you are going. So I tried to put the TPLO plate in a certain position that allowed me to avoid all these implants, and that's why you can see it's a little bit caudal on the proximal osteotomy of the tibia. So that's what you can see. There is, I will tell you on the next slide, that there is a problem with this radiograph. I had too much advancement of the femur, which is not good. So we have a little problem with the surgery. I put too much tension on the cranial cruciate ligament and not enough on the caudal one. So next slide, please. Yes. So we had 2 and 7 months post-operative X-rays. This is what I'm telling you. I have an abnormal advancement of the femur, so it's over-tensioned. But we had no unraveling, no osteomyelitis, no ovalization of boreholes. So that's a very good plan. And orthopaedic examination at 4 and 7 months was more than I could expect, really. Despite the imperfection of this tension that I created, we had a full mobility. We had no tibial thrust, no pain, sometimes a very slight lameness, but it's really difficult to see it. Perfect to trot, gallop, jump, sitting test, and no skin infection or fistula. So on the next slide, you can see the results. So I just forgot to tell you that this dog had 2 months of bandage with splint. Why? Just because when you have a collateral ligament, it's very, very difficult to say that everything is going to be okay. So I really did the maximum of what I could to have the maximum stability, but I didn't put any cast, I didn't put any transexternal fixator or so. So please, you can play the video. It's a stop and start of this dog. So it's a very powerful dog, and he's not really, he doesn't have any handicap for now. He's a very happy dog, very comfort. And so you can play the next video on the next slide. You can see that he was seated before the sit and run. Here is another video of the owner that is showing that is very wagging tail, very happy dog, but also he's able almost sitting here and now doing some little exercise. Now you can also see that he's going to go away with a little bit of trot, jumping all the time, and trot is okay. Next slide. Again, trot. At the very end, I saw that it was a little bit wobbling, but I think we cannot find any problem with this dog. So I hope you enjoyed it. So yeah, that's the last slide. I put this sentence because I think it's very true, that humility comes when the results exceed our expectation, and nature helps us sometimes and tolerate some of our imperfections. So I think, yeah, surgery is a kind of humility that you have to learn every day. And thanks Eric Viguier to learn me that when I was a resident. So okay, I have some question also. Why did I put cranial cruciate ligament and a TPLO? It's just because at this time when I performed this surgery, we didn't had biomechanical studies that was enough strong to my feeling for such a strong dog, a very, very muscle dog. And so I prefer to do a little bit. So I didn't told you, but the TPLO was not fully, completely corrected, but I wanted some help, at least for the cruciate ligament. I didn't want to be relying only on the cruciate ligament with the implant. But now, Eric Viguier at Vetagro and Novetech and me, we had done some more studies, and we know that with 2 screws, like we are going to teach tomorrow in an EPU in Lyon, it is enough to have good repair. Did you consider CBLO instead of TPLO? Yes, that's a very, very nice question. I really think that we could do a CBLO, at least of a TPLO, and it would be a good idea also because we could put the osteotomy lower. That's a very nice one. Eric Viguier is saying that we have 35% of pivot shift on the TPLO, and it's nice, of course, to have also the implant that is doing the job for rotation also. So it's not only the TPLO, it's the TPLO plus the implant which is going to be better. Yes, Eric Viguier also, for Artrex, he said that their plate has a hole to place the suture, so, you know, to like a tightrope. It's a very nice one also, but here I was dealing with another implants. Okay. Which is the benefit of the long term, for the long term of this technique? Less arthritis. Yes, we do think that if we do implant rather than TPLO, we do think that because we don't have the problem of valgus and rotation that is not corrected by the TPLO, probably we can say that we could have less arthritis. But you must not forget that anytime you are going inside a knee, you will have a little bit of arthritis anyway. Were your meniscus at the time of surgery? Oh, yes. How were there? The medial meniscus was completely torn. The caudal the caudal horn of the meniscus, of the medial meniscus, was completely cut. So I had to debride it, and but the lateral one was still well placed and still attached to the femur. And concerned long term about the caudal displacement of the tibia, that's true, but maybe because we don't have the caudal medial meniscus, maybe it's better for him to be a little like that, but I don't really think so. It's probably more a deficient technique here. Someone is asking me the order to put the prosthesis, but this is very, very difficult to explain in 5 minutes. So maybe Pierre-Yves Menez can ask me in another way, maybe by internet, or if he wants some more information, or if he can come to the EPU if he wants to. Replay will be available, I think. Yeah, Eric Viguier is telling us that arthritis will be more in the lesions that are added, and the problem of the meniscus probably will be a problem. He said that in some cases he's suturing it. He's suturing the caudal horn of the meniscus, and which is also a good alternative.
More than only suture the caudal horn. Very often you can have a detachment of the meniscus from the femoral part or the tibial part, and in this case I resuture the meniscus on the capsula, on the tibia or in the femur. And sometimes I have also some more than disinsertion, so I suture the lesion of the meniscus, and really I think that it's the best way to repair than to remove. And for the majority of the luxation, I speak about dogs who have a very, very high level and powerful lesion with a real luxation, and more than two or three ligaments were broken. And really, the knee is very unstable. And in this case, it's really difficult to repair, and really you have had a good result. As you know, it's very difficult. Before it was a real challenge to repair, and very often we didn't have a ligament enough strong, and we tried to do something for the caudal ligament. I repaired, but really, I think that my repair on the caudal ligament has no function. I did the repair, but I think that I have done was quite nothing, and the effect was null. But the more important is to repair perfectly the collateral, and they must be strong. And the problem is, until now, it was difficult to have something really strong. And we have, and but sometimes I have had some problem with fixation. And now with the interference screw, really, I think it's more safe to use the interference screw. Independent certainly of the ligament, but ligament now we can find even very small ligaments are very strong. But the problem is the quality of the fixation. And really, if you fix with a screw, or if you fix with a washer, if you fix with a tunnel and nuts, and you have some rupture of this fixation. And really, now we have a secure way to fix the ligament. And I think we must continue in this way. And it's a really good deal to do like this.
Yeah, I think everything is what said Eric. The collateral lateral for me was the main problem of this surgery. Anyway, we struggle to find a good surgery, but now I think with this kind of interference, it's a kind of breakthrough, probably. Any other questions? Someone fully agree with you, Eric, about suturing the menisc?
Yes. Oh, 4-0 proline, by example, a very small suture. Sometimes 5-0. It depends the size of the dog. And I have I use two. I have a special needle, and I use a device with like two. It's like two tubes parallel, and I put the needle. I put the string in the needle, pass through the meniscus, and I can fix the two parts of the meniscus with this device, and I use the suture out of the capsula. And sometimes I fit the caudal horn of the meniscus with a suture within the medial part, in the posterior medial part of the capsula, and only with the suture in the posterior medial, with two sutures of the meniscus. The medial meniscus is fixed and it has no movement, but it's more difficult for the lateral. You can't fix the lateral meniscus because it moves a lot on the tibia. But really, the medial meniscus is a meniscus who has no many movement on the tibia. And really, it's easier to fix the medial because it can heal easily on place. But the lateral is always moving, and the only thing I do is to fix laterally, but not caudally and frontally. But if I prefer to repair the lateral part of the capsula because he has to move, and he moves. He has a sliding movement on the tibial plateau, and sometimes big dog, quite 1 centimeter. So you can verify on anatomic on a stifle where you remove from a dead dog, and you verify the The medial meniscus move a few, and lateral is moves always a lot. So it's not the same way to repair, but we have no many information concerning that. So we have to try, and we do. But one thing, try to repair.
Okay, yeah. So, Victor, do you want to end this conference?
Yes, it seems that there is no any more questions. So, well, I wanted to thank everyone for its attendance, and especially the three of you for your conference. Thank you very much. At Novetech, developing a physiological solution, we are very proud of being able to support such initiatives like IGOS Group. So thank you very much for this, and well, we can finish this webinar. Thank you.
Thank you. Thanks a lot. Goodbye.